Hello and welcome to our third webinar in our Family Drug Court Learning Academy series. The theme this year is Leading Change. My name is Jane Pfeiffer and I'm a Senior Program Associate with Children and Family Futures, and I'm going to be one of your presenters today. Today's webinar is entitled Leading from the Front Lines, Case Managers in Your Family Drug Court and Why You Need Them. Presenting along with me today are Jocelyn Gaynors and Dr. Tara Doty Mundell from Baltimore, Maryland Family Recovery Program, and Jim Nickerson and Kathy Lehman from King County, Washington's Family Treatment Court. Our learning objectives for today, we're going to focus on key functions, challenges, and opportunities of case management in the family drug court setting. We're going to hear from lessons learned from our panelists who come from different team member agencies providing case management services to the parents and children in their family drug court program. As we get started, we wanted to just let you know that we recognize that case management, especially in the family drug court setting, is a shared function. We'd like to hear from you who in your jurisdiction is providing case management services. Whether or not they have the actual title of case manager or not, we want you to answer the question that you see on your screen now. Who provides case management in your family drug court? And here we want you to check all that apply. We'll take about 5 or 10 seconds to give you a chance to answer this. Okay, so for folks who responded to this poll, we see that 69% of you said that Child Welfare Agency was at least one of the organizations or agencies providing case management. Not a surprise there. I know in many family drug courts they are the primary case manager, and others it's another agency. And you'll hear from our panelists a bit on that in a minute. Substance abuse treatment, 44% of you said they're providing case management services, court or community-based. Recovery support specialists, and then 19% of you indicated that it's an other agency as well. So as we start our webinar, we see it as our job to help you identify ways to strengthen your practice and to develop a plan to get where you need to be to providing evidence-based and evidence-informed practices in your family drug court. Our goal is to share the best and effective practices and to provide technical assistance to help you. It's our responsibility to provide you with the information and the resources to achieve that. And we know that we can connect you to other family drug court sites that are doing these particular practices as well. We're highlighting 2 family drug courts today that are part of our Peer Learning Court program, and we'd be happy to connect you with them as well as other services. But as I say this, I want you to be thinking about, as you hear these practices, as you hear some of these strategies today, I want you to be thinking about your own practice as it relates to case management and really what the areas for improvement are. One of the ways in which we are pushing the field to consider their case management services has to do with the coordinator position and your case managers or the case management that's being conducted. Now, some of you have a family drug court coordinator or program manager, perhaps, or by another title, but you have a coordinator who is also providing case management services. Our webinar last month, which is archived on our blog, was about family drug court coordinators. And we make this link here. We talk about this here because we know that there are a lot of family drug courts out there where the coordinator is providing direct services to parents and children in the family drug court. And we take the position that that's not a best practice. That ideally, and really where you need to get to is to have separate positions, separate individuals who are carrying out the functions of a coordinator and separate individuals carrying out case management functions. We have found that while both are leaders and both have a role to play, if there's one person trying to do both, it's very likely that that person isn't doing either one well or well enough. And that really comes down to a matter of time in the day. There are drug courts out there. There are drug courts out there that have started with a coordinator position providing direct case management services, and primarily they did so because they perhaps had a small number of families. However, you can keep your program small, or you're forced to keep your program small if you can't expand, if you're not able to expand because you don't have enough case management resources. So I ask you all today, those of you who have your coordinator carrying out case management functions, to really think about how you can create these two positions separately, that your coordinator, while they may be participating in some of the coordinating functions of case management, that they're not the ones responsible for those direct service responsibilities. Another area where we're asking you to raise the bar and to consider is as it relates to serving children in your family drug court. Family drug courts very clearly have a responsibility to serve both children and parents. Even if you're working in a parallel court model, a parallel family drug court model, the family drug court team really must be aware of the service needs of children, and it's their responsibility to help to ensure those services are being delivered. Now, the slide that you're seeing now in front of you is just a partial list, really. It's a partial list of the type of services and needs that children have. And depending on your drug court and the relationship you have with your community-based organizations, we know that there may be just a number of different agencies and organizations providing these services. But the challenge here really is for the family drug court not to be separate from that responsibility of tracking and being aware that children are getting the services they need. We know that we absolutely know that we should be focusing on family recovery, and that really includes us looking more specifically at serving children and making sure that the needs of children are being served either within the context of our family drug court, but certainly with our family drug court being responsible for ensuring those services are being delivered. Now, here is, throughout our presentation today, throughout our webinar, we're going to provide resources, show you links, and mention various resources. As you see, this is a case management monograph that was published in 2006. It provides an overview and some considerations for case management in drug courts. So we share that with you as we share some of the information that comes from this document. So let's talk for a moment about case management models. These case management models have been around certainly for a long time. We know that in 2000 they were pulled together in this way. These four particular models to show the different kinds of ways that services can be delivered. Many of these initially were brought together around serving individuals with mental health issues, and since that time have been applied to individuals with substance use disorders as well. And so we're going to talk more about these, but we want to frame the conversation, and we ask you if you haven't thought about which model, and it's probably more than one, if you haven't thought about which model, we really encourage you to think about it and to consider, once you hear a little bit more about them, where that fits in terms of your program. So let's start with the first two: broker generalist and strengths-based. Again, I mentioned it's very likely that when you hear these, if you're not familiar with them, that you're really going to believe that or come to realize that you're using a little bit of all of these, perhaps. And when we get to the next slide, I'll talk about where you should be focusing the majority of your efforts in this area. So broker generalist, where this fits in the drug court model, if anywhere, is in the intake, at intake. This broker generalist really is where the individual might have a high caseload, which is typically what we don't see in a family drug court. But the idea is that the person is simply making linkage and referral. So timeliness happens because the person is able to do what they need to do and then get that person to move on to where the service is actually going to be delivered. So we sometimes see this type of model being applied in the intake setting. And then, of course, there are other case managers or others who are providing other support and services after that point. The strengths-based model, you'll hear more about that from our Baltimore, Maryland presenters here in a moment. But the strengths-based model really comes out of some work of Dennis Salibi, and it's an opportunity for us to move from a deficit-based position where we have been for decades, really, in both child welfare and substance abuse treatment in some ways. And it's a way to support clients recognizing their strengths, which is how, in fact, they're going to address the challenges that they face. The next two case management models, assertive community treatment and clinical rehabilitation. I want to spend a couple of minutes talking about assertive community treatment because we know that this is an evidence-based practice. It was developed initially, as I mentioned earlier, for use with persons with mental health diagnosis, but it's since been adapted for persons with substance use disorders. It's intensive support and assertive outreach. It's one of the principles or one of the descriptions, part of the description of it, it really includes home-based services as much as possible, providing support, making that support available as close to 24/7 as possible. Community support is one of the hallmarks of assertive community treatment. We know improved outcomes occur when assertive community treatment is the case management model that's used. When you look at these bullets, intensive case management model with low caseloads and frequent contact, multidisciplinary team approach which provides many services directly and monitors services delivery when referred outside, that describes a good and effective family drug court. And so learning more about the assertive community treatment model of case management can help you assure that you are maximizing the impact of your case management services. So we introduce the concepts here, we introduce these models here, and we encourage you to learn more about them if you're not familiar with them. The last one is clinical rehabilitation. Again, this is often a part of what's being delivered in family drug courts, but this is where case management and clinical treatment are integrated. And we see this happening in a number of our family drug courts across the country. So here are the 5 case management functions, key functions of case management. And notice here that on this slide that we don't say case manager. And we do that intentionally. We know that there are individuals, hopefully, probably working for you, working as a team member who have business cards that have the title of case manager. But there are many others who have other titles who are providing some case management. As I mentioned, the challenge, maybe the greatest challenge with case management in family drug court is coordination of these various functions, since we have so many people who are carrying out and delivering these services. So as a team, you really must be sure that all the functions are, that you know who's carrying out these functions, that coordination is at the forefront of your considerations. To talk about these functions for a moment, it starts with assessment. Assessment, to borrow from the 12-step community, we often say that assessment it isn't an event but a process, that certainly assessment should happen early, and we should be doing thorough early assessment, but we also want to make sure that assessment and reassessment is happening over a period of time. And then the second function is planning or case planning. So we know that it seems like that this is a given, but that the assessment, the results of the assessment should be linked directly to that case planning. Case planning then leads to linkage. Linkage really is more than just a referral. A referral might be a one-dimensional type of process where you'd hand a phone number, a name and a phone number to a parent and expect for them to carry that out. Linkage really is more maybe perhaps three-dimensional. The idea that the linkage is something where you are going to know what services are available in the community. You're going to make you're going to know that parent well enough to make a good connection. You're going to you know the capability and the abilities of the parent so that you can support them and not making sure that you know whether or not they're able to make that contact on their own or whether they need some additional support. Monitoring. Monitoring is more than just finding out whether someone attended, but it's really monitoring someone's not only attendance but participation, understanding and making sure that that linkage was effective, that it was a good fit, that it continues to be a good fit. And then lastly is advocacy. And advocacy is certainly advocating for that parent, finding support for that parent. But as we certainly as we know from assertive community treatment, part of that case management model involves making sure that the community is engaged, that we're helping that parent connect, that family connect to specific supports in their natural community to allow them, long after family drug court is out of their life, to be able to continue to advocate for themselves. And sometimes that's a series of skill development. All right, so I'll just stop here for a moment and let you take that picture in. I know any of you who are doing case management, have ever done case management, that you can relate to that photograph, I'm sure. We know that there's a reality, right, that no matter how small your caseload is, it's still very demanding. We know that that the realities are that you should not only work with others who are providing case management services to the families that you're working with, to be client-centered, to take into consideration the role of child protection, the high degree of accountability that our family drug courts include, and we know that cross-training is an important piece to what's expected of case managers and all of our team members. This slide here is some information, and there's a lot of other results that we could share with you, and that we certainly can share with you. But we included this slide, which is the regional partnership. It's information about what happens when we include recovery support specialists or recovery coaches in case management. When we include intensive case management with peer or parent mentors, or as I said, with recovery coaches, that we particularly parents experience a longer length of stay in their substance abuse treatment. So we know that it's not only that parents and children, families are getting their service needs met, but we know that it's linked directly to how long a parent stays in substance abuse treatment. And we know that the longer a parent stays in substance abuse treatment, the better their outcomes are. So there's good research and there's good reason for us to include intensive case management and certainly recovery coaches into our process. Just a couple of comments about this next slide. Those of you who attended our webinar last month heard Teresa Lemus share some information about leadership. We think that these domains, these leadership domains, really cross over all of our team members. What's unique for case managers or others providing case management services really is that that you come to the job as a case manager or someone delivering case management services. You come to your work. You came to this job probably with one or more of these as a clear strength, and perhaps others of these not as much. And so we encourage you to consider these domains, to look at these, and to develop a plan for yourself to increase your skills, your knowledge, skills, and abilities around those leadership domains listed here that perhaps are not as strong for you. We see that this is an opportunity for all team members, but certainly case managers to consider this and to consider how this fits for the work that they're doing. And we'd be remiss if we didn't talk about sustainability. We'll talk to our panelists here in a moment too, but we know the importance of sustainability, and this slide here shares some information about a webinar that was presented back in 2012. And what I would suggest you do, if you have a chance, is to take a listen to this entire webinar. It provides information specifically about case management services, functions of case management, how they can be funded, and it walks you through, it really walks you through how you can think about sustainability for your entire program, certainly, but the example that's given, and you'll hear from one of our panelists here in a moment too, but it really walks you through looking at the existing resources that are available and helps you go through the process of identifying existing resources rather than necessarily looking for new resources, but looking at existing resources to fund the case management function. This, both the webinar you're listening to now and certainly this webinar from November are all archived and available on our on the Children and Family Futures website and on our blog. This is the process that we recommend. We suggest that you, and this is the part that's on the webinar that I just mentioned, but just really breaking it down by looking at a job description. Hopefully there are job descriptions for all case managers. What are the current funding sources, what funding sources are available, and then what's the best match with existing funds. And so again, we encourage you to look at that webinar to learn more about that. All right. So I want to remind you to use that question box. We encourage you to ask questions. I know I'm going along here pretty quickly. I want to get to ask our panelists some questions, and so that we can hear from them. We'd like for you to, though, throughout the presentation, to ask a question in the chat box. Our panelists today, we'll have them introduce themselves. Our panelists today come from King County, Washington, and Baltimore, Maryland. As I mentioned earlier, they're both peer learning courts, Family Drug Court peer learning courts, which means that they're available to you to share additional information. We have much of the support documentation and paperwork and so forth, some of the forms and support documentation that they use in their course that might be useful for you as well. And so we're going to start introductions. Let's start introductions with King County, Washington. First, let's hear from pardon me, let's start with King County, Washington. If you could introduce yourselves and your role and be brief background on your family drug court and community.
I'm Kathy Lehman. I am with the King County Family Treatment Court. I'm one of two treatment specialists in our program. We have two sites that we hear hearings. So we have one court that meets in Seattle and one court that meets further south in a more rural area in South King County. I'm the treatment specialist for the South King County Court. I also do intakes for the program, and I've been with the program about 10 years, and our program's been in existence about 11 years.
And I'm Jim Nickerson. I'm the supervisor for the Family Treatment Court unit, which is part of Children's Administration for the Department of Social and Health Services. It's a region-wide program, which means that we serve all of King County. King County is a quite diverse population. We have probably 300 children in foster care per year. We also use a lot of relative placement and suitable adults. And things about King County that make it challenging is the fact that in a positive stroke, we have a very thriving economy. We're home to Microsoft, Amazon, Starbucks, Costco. That also has raised the prices of our housing, which creates another issue for our clients as they come in and live in this community. We're home to the Seattle Seahawks, the Seattle Mariners, and it's a great place to live. One of the reasons I like working in this court system in King County, and I've done it for a little bit of time, is the fact that we have a long history of working in partnership with the judicial bar, the department, and very supportive in regards to children that are in the dependency system.
Some other facts about our program, and in King County, we are an integrated model, and as I said, we've been in existence for about 11 years. We currently have 5 social workers in our program who are dedicated only to our program, so they only have cases with us. They each have 12 kids on their caseload. Also, as a treatment specialist, we work in a partnership with the social workers, and as I mentioned, the treatment specialists are the folks, we do the recruiting and we screen folks for coming into the program, and then we also get treatment reports and such and communicate those at staffings, and we communicate the progress to the other team members. All of our cases are heard at least every other week when they first come into the program, so we have really frequent staffings.
And the model the department uses up here is a solution-based casework surrounded by safety framework in regards. So we could currently assessing safety on a day-to-day basis for the children, as well as being very solution-positive based program.
Yes, we are a very strength-based program as well.
Thank you. Thanks so much. And I neglected to say this perhaps before I introduced you both, but as you'll notice, our King County panelists today come from Child Welfare and Treatment Agency, and our goal here with our panelists is to share information from 2 sites that are delivering case management in some different ways. The outcome very likely the same or similar, but the message we really want all of you to be aware of is that there are a number of different ways that case management functions can be carried out, can be delivered, and different agencies or organizations who can do so in a very effective way. So with that, let me move on to our Baltimore, Maryland panelists.
Hi, good morning, good afternoon, good morning. My name is Dr. Tara Doty-Mundell, and I serve as the clinical supervisor here at FRP. And I'll just provide a little bit of background about Baltimore. Baltimore City is the 4th populous state in Maryland, and Baltimore City is known for heroin drug use. We have actually been #1 in the country for heroin use, and heroin overdose accounts for 48% of all drug-related deaths within Baltimore. Each year, approximately 2,000 children from Baltimore City enter into the foster care system, and it is estimated that 66% of these children have a direct linkage to parental substance abuse. Looking at the Family Recovery Program specifically, data from 2007 to 2011 show that 83% of our clients are female, 59% are African American, and 38% are white, and heroin is also the #1 drug of choice for our clients, with 48% reporting that heroin is their #1 drug of choice.
Good afternoon. My name is Jocelyn Gaynors. I'm the Executive Director of the Family Recovery Program here in Baltimore. The Family Recovery Program was created in 2005. I joined about 2007. It is based on a model of Family Recovery Program from San Diego, California. Currently, we have 2 locations, one here in Baltimore where we operate a parallel court model. We have, on average, about 100 clients per year. And we recently were awarded an opportunity to provide case management services in the District of Columbia, where we have 4 staff, 4 case managers, with a total of about 15 to 20 clients. In 2012, we became a sustainable nonprofit. We left the company that started us, and we became our own individual agency. We are a voluntary program primarily for individuals who are 18 and over. The average age of all of our clients is 33. We have very intensive case management services where we make treatment referrals to all different types of modalities of treatment located here in Baltimore and DC. Here in Baltimore, we have on-site mental health services, family treatment. We also have services for children offered through our on-site mental health care. We run evidence-based practice groups such as Celebrating Families, Seeking Safety, Circle of Security, and we most recently added a new one, Helping Men Recover, which is a trauma program for men. Also, we offer on-site adult basic education and GED services. We have on-site drug testing, and to make all of that work, we have on-site child care so that our parents are able to participate in all the groups I just mentioned. All of our staff have been trained in motivational interviewing, and we really are interested in making sure that our whole entire team is trauma-informed. We were evaluated by MTC Research in 2008, and they decided at that point that clients who participate in our program, their children have shorter foster care stays, they have greater reunification rates, and there's higher treatment completion. The most recent thing that we're working on is we are moving into housing, so we're excited about that change.
Thank you, Jocelyn. Thank you to all my panelists. Now let's shift gears a little bit and ask you some questions about the differentiation of roles and functions. We know, and I probably said it more than once today already, about the challenge of coordination. You know, if the good news is that case management is intensive in the family drug court setting, and that there are many who are delivering case management and carrying out case management activities, if that's the good news, then of course the challenge really is how do you coordinate all of that so that there's not duplication or issues with information sharing? How do you coordinate that case management? And so I ask, and we'll start with Baltimore, and Jocelyn, how do you differentiate the roles and functions of various staff doing case management related activities in your program?
Well, thanks, James. One of the things that we do to alleviate client confusion is we have separate office locations. So our family dependency court is located actually across the street from our family court, and our Department of Social Services is about 2 miles away from the office. One other thing that we do is we have different titles for our staff. Some of our staff are called case managers, and some are called recovery specialists. But what that requires is that the staff must know that role, whatever role that they have, and they must communicate that specifically to the clients. So all of our staff here understand that they are not social workers, and that their main focus, although we are concerned always about children's safety, but that is not our main focus. That is primarily the focus of the child welfare workers that we partner with. Our main focus here in Baltimore and DC is to focus on reunification, those barriers, and how we might go ahead and work through those barriers to reunification. With our clients here in Baltimore, one of the ways that we change the role and we look at the role differently is that we have the opportunity to stay connected with the clients in creative ways. One of the jobs here in Baltimore is that of a re-engagement specialist, and that individual's job is primarily just to go out into the streets and look for clients who are no longer interested in being a part of our program and offer them an opportunity to get re-engaged. We also have a lot of in-office sober activities such as ping pong. We purchased a ping pong table for about $100 a year or so ago, and it provides an opportunity for great fun. We also have 12-step meetings on site run by our alumni. We always have a television running, and we always have snacks in the office. So we make sure that we're differentiated not just by who we are and what we do, but how it feels when you enter the family recovery program. It's very warm, it's very welcoming, and the clients know specifically who their case managers are and what work is expected from those case managers. We work in partnership with the Department of Social Services in both Baltimore and Child and Family Services in DC to ensure that the clients are clear as to who does what role.
Another way that we differentiate the roles and the functions of staff is that when our case managers come in, they are trained using that strengths-based case management model, and you actually refer to it on slide 14 where you define the 5 major areas that a case manager really addresses, and the first being assessment, which is the initial intake and the TAP assessment. We also do a mental health assessment, and then we refer out planning, which we believe is ongoing and based on an individual client, each individual client. Linkage, being able to collaborate creatively with partner agencies to get the clients the services that are matched based upon their needs. Monitoring their progress and their performance. And one of the things that I think is special about that monitoring component within the Family Recovery Program is that each Friday, case managers attend a docket conference whereby all team members are present and each client who's scheduled to appear for court that day is discussed. So if we have concerns from the case management perspective or even the re-engagement specialist, they're able to come together in that meeting and discuss creative ways to address the client's needs and support them in their one, their recovery process, and two, in their reunification process. And also in that docket conference, the case managers really get an opportunity to advocate for their clients. And I think that empowers the case managers to really present their knowledge and expertise on each of their individual clients and their caseload, as well as giving them opportunities to work creatively with some of our partner agencies to identify and then subsequently meet the needs of our clients.
Thank you. Thanks so much. Now let's hear from our King County, Washington panelists. Kathy, would you like to start off?
Sure. We do some similar things, I think, as Baltimore. One of the things that we do is when a case comes into our program, within the first month, we schedule a first team meeting, and that's where all the team players sit down with the parent, and we start off with identifying roles, who does what, and we clarify contact information to make sure the parent knows how to contact everyone on their team, and we have contact information for them and maybe a few alternate contacts as well. We identify our roles, and then we also talk about what's in the court order. So we'll talk about what they're as part of their dependency case. And then we talk about what next steps are to either get those services started if they haven't already, or how to get them going and how to maintain. We talk about maybe problem solving as far as like transportation, to have an ORCA card, which in Seattle is a bus pass. And we make sure that any barriers are eliminated so people can get started with a good pathway to know what to do to get going on their court-ordered services. And then we also differentiate our roles in that the treatment specialist, we would work on getting people set up in drug and alcohol services, mental health services, maybe help them find sober support meetings. We might do a backup on, do you have your ORCA card? Are there any other barriers we can address in getting you to services? Whereas the social worker that we partner with on the case would be focusing more on the children's needs and the children's services, what they need to do with that. So then we all will have team meetings periodically throughout the life of the case, especially during transitional times. Like say a case is getting ready for a transition home, we would have a team meeting where all the players come to the table and we'd identify what steps do we need to take, what logistics do we need to work out with transportation, hours, placement, anything like that. We would pound those out, and then the other treatment specialist and I will send out notes that's a summary of the meeting, and we try to get those out within the first 10 days so that everyone on the team is very clear on what their next step is to do. We also communicate, a lot of communication via email, and because of confidentiality, we do not send out names in emails, so we kind of code it by name. So each of our participants has got what we call an FTC number, and we would communicate very frequently with those numbers via email. We do a lot of tie-ins, and of course we have the frequent staffings in the team meetings.
Thank you. Jim, anything to add?
Sure. Yeah, from the department's perspective, it's really a collaborative effort, and a lot of times, I don't think the specific task is one that is restricted to a particular player. A lot of times, especially in regard to treatment, what the treatment specialist will do will take the lead in regards to getting it set up and working with that individual. But it's really a collaborative effort between the department social worker and the treatment staff and the whole team to make sure that it occurs. We work on a legal standard of reasonable efforts, but in FTC we do the term's escaping me right now, but it's the next level up and the types of efforts that we are made. And we go that extra step to make sure that an individual gets there. Even if they have a bus pass, even if they need to get to treatment, as a team, we will make sure that that happens and stuff. So there's a lot of hands-on, a lot of close connection. Baltimore talked a little bit about the staffing system. Specifically, we staff every case before each hearing with all the parties there, the judges there. So when we get into that hearing process, the message coming from to the parent is strictly coming from the bench, and the judge has a direct relationship and is able to express to the parent what the expectations are. Another process that we use quite extensively, we wish we had it for every case, which is called a RAP service here in King County. That's a mental health facilitator. that basically is assigned to some more difficult cases, and that is another process where they go in and they have a process of becoming the voice of the client for parents that are struggling, for parents who are not getting what they want, for parents who feel they're not being heard or that things aren't working for them. We want to make sure that we process that outside of our system to be able to bring that back to the court so she can make sure that the clients are understood and heard. The social workers, their primary focus is the children and making sure that they are safe, making sure that their permanency planning is continuing and that we are moving towards permanency for the children. But we also want to make sure that we're integrating into the planning process that when these children are reunified with the parents, that the parents and the court understand the specific needs of this child. We find that a lot of the parents' children, when they do get reunified home, they have their own issues from being in an addictive family over a period of time. And even the best parent could struggle with the children. So we have to make sure that we've worked on that process. We've done a lot of work lately in regards to making sure that when the children are returned home, that the family is really grounded into the recovery community, that they have the community supports that they have, that recovery culture is part of what exists for the client. At least that's where we find the most success, is when the clients can connect to the recovery community prior to having the children return home, and that's a big emphasis. We've even gone to the point of during our celebrations and our graduation ceremonies, as part of the recovery community, we start off the process with a serenity prayer, and that was a request by a lot of our clients, and that's added a nice homey feeling to the process.
Thank you. Thank you to all of our panelists. The next question is about lessons learned about effective case management, and I think you've certainly covered perhaps some of the answer to this question. Let's start with King County this time. Tell us some of the key lessons learned in your efforts for case management in your program.
I'm probably going to take off where I left off in regards to that process, that when we have that reunification and when we're moving towards getting that person connected to their community, getting connected to the natural resources that are necessary to survive, to be able to be continuing recovery, that a lot of issues in regards to finance, in regards to occupational types of counseling, getting them sustained so they can maintain within their own community is a big challenge. We do a really good job, I think, in the past of addressing the drug addiction, as well as doing a good job of addressing the trauma and addressing the mental health and getting that all in there. But then there's life, and how do we help that person adjust to life, and how do we make sure that when they're in the community, they know where their resources are, and they know where their recovery community is, and they know what to do in a case of crisis, or to basically reduce the stress. I'm a firm believer that stress is one of the #1 causes of relapse, and so we have to make sure that they stay ahead of that so they can maintain their sobriety. And I think that's going into our third stage of our programming, and we put a lot of effort into that to make sure that they have the resources necessary.
I was just going to add to that. I think some other key things we've learned are to definitely build those relationships with service providers within our community. Also to have kind of respect for our other team members' roles, and maybe not try to armchair quarterback or second guess our partners, is to give people the respect of doing their own role. Another thing that has really been beneficial to us in case management is involving the veteran parents. They have sometimes come to our meetings, come to an intake perhaps, and talk to people. And in some cases, they've almost served as an interpreter for us. An example I can think of is on one case we had a mom who maybe really wasn't engaging in treatment, and what we were almost kind of viewing as non-compliance. When we brought the veteran parent in to help us kind of understand what was going on, the mom was actually kind of afraid of writing a first step or talking in group, thinking if that gets back, maybe she might have something to share, that she was worried that if it got back to the team, she wouldn't get her children back. And in reality, that's not true, but that's kind of where she was stuck, but she didn't want to talk to the team about that, but she would talk to the veteran parent. So they've been instrumental in helping us with engagement. Another tool our program used is at our retreat this year, we tried an exercise where the entire team, it was mandatory, the entire team came for a day, and each person was given a card with an identity on it. For example, I had a dad who was like 41 who was diagnosed as cocaine dependent, and then we were also given cards for tasks. For my cards, I was asked to go do a drug and alcohol eval, a psych eval, and do a UA, and do a sober support meeting. And you had a limited amount of time to get those tasks done. You had to go to different tables, and different barriers might have come up for you. For me, I was in the middle of my drug and alcohol eval, and I got handed a card that I was being sent to jail. I got arrested. So it really helped our team kind of learn, I guess, gain more insight as to what we're asking our participants to do, and gave us, I think, kind of a common understanding, common language of this is what we're asking parents to do, and it can be really hard. One of the best parts of that is that we had our veteran parents come and help us process what it felt like, and they gave us some very real information about their experiences in the dependency system that helped us learn more about how we could do things a little differently.
Thank you. Thanks so much. Now let's hear from our Baltimore, Maryland panelists. What are some of the key lessons learned about effective case management?
I think the most important lesson that we have learned is that we have to invest in staff development. We have to invest in our staff. In order to continue to provide services that exceed expectations, we have to make sure that our case managers feel like they're supported when they're doing the work. And so one of the things that we really emphasize heavily when we do staff development is time management. How do you balance your clinical aspect with the administrative aspect, making sure that your notes are submitted on time, making sure that you're submitting reports that are free of grammatical and unnecessary spelling errors. We also utilize a theoretical framework. We start with a strengths-based case management approach, and within that we incorporate different techniques associated with motivational interviewing so that our case managers, it's not as subjective, but it's objective. They know how to roll with resistance. They know how to practice reflective listening. They know how to develop empathy for their clients. We also stress ethics. We do ethics training, an 8-hour ethics training per year where we talk about boundaries and professional competence. We also approach each client from a trauma-informed perspective. We understand here at the Family Recovery Program that both addiction and involvement with child welfare are both traumatic experiences for a lot of our clients, not to mention homelessness that many of them experience or co-occurring mental health disorders as well. Another thing that we talk about is utilizing a multidisciplinary approach where the clients are active participants in their own futures. They facilitate that future, and we work with our case managers to make sure that we eliminate client-identified barriers such as lack of transportation, legal issues, to successful completion, reunification, and then finally family stability. We also develop creative partnerships. We have on-site mental health services. We have on-site parenting classes, on-site educational classes. That allows our case managers to remain in their role, and it also makes FRP a central location. One of the things that we have found in doing this work is that our clients can get overwhelmed. One of the basic skills that we work with clients on is, one, making and maintaining appointments. It's easy to make the appointment. Can you maintain it? And with us serving as a central location, so many of our clients' needs and some of those identified barriers can be addressed right here in a safe place. We collaborate with other agencies for workforce development. If our clients need assistance with expungement issues, we have some place that we can contact right away. When a client brings it up, our case managers in that same session are giving them a referral. And to kind of manage all of that, we also provide clinical supervision of their case managers. I meet with the case managers on a weekly basis where I will either randomly pick about 3 clients, or I will allow them to bring down 3 client charts where I review their notes. And I ask them questions about what's going on with the client, how is the client progressing in their treatment, how is the client progressing in their reunification process. And that's done as a way to really help the case managers prevent burnout. Because we want our case managers to build and maintain their relationships with their clients.
In addition to that, one of the things that we believe here at the Family Recovery Program is that case management is only as effective as the individual who's providing it. So we have to have individuals who work, case managers, recovery specialists, who work and are passionate about working with clients who are struggling with the addiction. We have to have individuals on our team who care about the children. So you can't just do this job for money. This job has to be one of passion. In addition to that, you have to have an effective case management system. You have to have a system that's able to actually manage the data. We just recently invested in a new system to try to improve our case management data system. That system now is much more user-friendly. The case managers can quickly identify who their clients are, see when appointments are, and really work better on their recovery plans. In addition to that, you have to be able to meet the clients where they are. Many programs are only open from 9 to 5. Here at the Family Recovery Program, we try to have hours that are more flexible for the clients. When we find out that clients work in the evenings, we do random drug testing here at FRP. We will identify 2 to 3 evenings a week and have staff stay so that the clients who work are able to engage effectively in our program. One last thing that really is important, and Tara spoke on it a few minutes ago, but that is the importance of creating effective partnerships. The strength of the Family Recovery Program, again, is only as strong as the partnerships now that we have. Working with substance abuse, mental health, housing providers, treatment providers is so very important. We have what we call an FRP staff meeting, and we have that meeting quarterly. And during that meeting, all of our providers are invited to sit down at the table, talk about their challenges, talk to all the case managers about the client specifically and their needs, so that we can all together become a much more effective team.
Thank you so much, and that's Jocelyn, it's a perfect segue to, it's a perfect segue into our next question around skills or characteristics that make an effective case manager. So let me hear from our Baltimore panelists about any additional skills or characteristics that make an effective case manager, what the role of supervision is in ensuring effective case management.
Sure. So the first thing that we look for in identifying case managers here is one is that they're teachable. You know, the view of addiction has changed tremendously over the past 15 to 20 years. And at the Family Recovery Program, we view addiction as a disease and one that impacts the entire family. And as such, the recovery process has to be just as comprehensive, including the entire family or that client's identified support system. And so we want our case managers to be teachable, to be willing to learn. We want them to have effective time management. Our case managers have about roughly a 20 client caseload, and they have to be able to meet each client's individual needs. And we do that, we gauge that level of services required through our intake process, where we refer all clients who need mental health services to our on-site mental health provider or outside services if the client chooses to go somewhere else. We recently began another evaluative tool where we have begun using the North Carolina assessment, where we do a baseline assessment within the client's first 7 days here, and then we also re-administer that assessment 2 weeks before discharge when we can. And we just work, and that has about 15 domains ranging from workforce, family life, parenting, social support, to see what needs we can work with the client to address as they progress through the program. Each client is also given a treatment plan that is reassessed every 90 days or when something changes on that plan. We also want our case managers to have the ability to initiate partnerships. If we know that a client has a certain need, we don't need that case manager to hesitate to begin to reach out to initiate a partnership with a potential agency. All of our case managers have a very good understanding of addiction. All of them are certified addictions counselors. And with that, they bring to the table also education for our clients to help them understand the disease of addiction and how it has impacted their life and how it has impacted their relationship with their children, and how they can work within that reunification process when applicable to teach their children about addiction and how they can learn to trust their parents again in their parents' recovery process.
As Tara said, one of the things that we really focus on with the case managers is time management. And I think as case managers grow, they become more aware of the importance of setting good boundaries regarding time management. Another point that I'd like to make is the importance of cross-training your staff. I think effective case managers have to do more than just be able to work with their client specifically. We don't like to have a client come in FRP and sit around because their case manager is out to lunch. So we make sure that our systems are available so that any case manager that is available can sit, talk with that client, and work with them intensely. In addition to that, We provide drug testing here, as I said earlier. So all staff here are trained in how to do drug testing. So that means that on any given day, any staff member could be working with a client in an intimate way such as that. Effective case managers are also made more effective by the system that supports them. So we try to have a flexible system for our employees. We try to have a family atmosphere. We try to always have good benefits. And lastly, we try to make sure that the program is adaptable so that when the case managers make suggestions or the clients make suggestions, that we're really able to listen to them, take them to our policy team, and make changes as necessary.
Thank you. Let's turn to King County then, and let us know what the skills or characteristics that make an effective case manager and anything about supervision to ensure effective case management.
Well, I'm a firm believer that good supervision starts with good hiring. And I think that one of the things I look for in regards to a potential employee is one who believes in the people that we're serving, ones who see the family as a whole, and ones who are willing to, support and respectfully make sure that the individual is achieving the goals at their best ability that they can. And once they're hired by the Children's Administration, they go through a 3-month training program. It's put on by the University of Washington, and in regards to, and then they're assigned a coach who goes through them and goes with them through their first initial case carrying experience. In regard to the clinical supervision of it, I review every single case on a monthly basis with them, and I also attend all court hearings and all staffings. So as a supervisor, I'm able to be part of the cases, have a good understanding of what the cases are doing, as well as being able to monitor how my workers are providing their information to the court and how they're interacting with the clients. Again, we're a dedicated unit. We have the 12 cases per social worker, but even with that, my actual life expectancy of an FDC social worker is on an average is about 2 years. They are in court every week, so that adds a little bit more to their thing, as well as with the different meetings that they have. They have team meetings they need to go to. They have court hearings they need to go to. They have RAP meetings they need to go to. If we're going to have any type of placement move, we need a family team decision-making meeting where we bring all the families and the attorneys together. They also have to participate, and they do a comprehensive family evaluation on the family on a minimum of every 6 months, and they have to assess for safety anytime there's a change in the child's visitation plan, reunification, change of placement, all reassessment in regards to safety. So it's a very, very busy caseload for these workers. So the one thing they also have to have survive is really good organizational skills. And nowadays for any social worker, I believe they have to have really good computer skills. And so, that's what I look for in a worker.
Thanks so much.
I think for the
Kathy, anything to add? We're sort of out of time here, and we're going to wrap up with a few last slides. But Kathy, anything you want to add here to this?
Sure. I think for the treatment specialist, for us, we would also, in kind of echoing what others have said, we would also look for kind of some clinical experience and maybe ability to handle emergency situations, like if there's a person who's threatening suicide. And we also really look for people who can collaborate with others. Our partnerships are really what make our teams work. So it's people who can work on a team and communicate very well. We also do weekly supervision with the program supervisor because we're actually court staff. We're actually employees of the program, and that supervision is really beneficial for us.
Thank you. Thanks so much. So as we wrap up here, I want to thank our panelists. If you have additional questions, please enter them in the question box. We are going to, let me just share this slide here. Baltimore City Family Recovery Court, as I think Jocelyn Gaynors had mentioned, there's a report that's been published based on a cost evaluation and cost savings rather, and there's npcresearch.com is where you can find that publication. The post-webinar is where we're going to answer the questions that have been posted during the webinar because we are out of time. And I want to go through just a last couple of slides. Our next webinar is Thursday, June 11th. You're going to hear about Prevention and Family Recovery Program. You can register on our blog. These are the rest of our of the webinars in the 2015 series. We hope that you'll take a look at our blog if you haven't seen it already. There's information about our peer learning course, podcasts, leadership resources, and more. We hope that you will complete our evaluation. We work to make these meet your needs to the greatest extent possible. We take the evaluations very seriously and really are grateful for the time you take. And as promised, here is the information about our post-webinar conference call. You're welcome to call and just listen in, or certainly the real goal is to have folks participate, ask additional questions. Myself and our panelists will all be on the call. And so with that, I would like to again thank our panelists from King County, Washington, and from Baltimore, Maryland. And we will now be ending the webinar, and we'll move on to the post-webinar conference call. So we hope to see you, listen to you all there. Thank you very much.